Introduction. This lecture on syndromes delves into the various brainstem and spinal cord syndromes, focusing on their anatomical locations, characteristic symptoms, and underlying causes. Brainstem syndromes are often classified based on the affected area, such as the midbrain, pons, or medulla, and the particular cranial nerves, pathways, or nuclei involved. These syndromes present unique clinical features that provide clues for localization and diagnosis. For instance, Weber, Benedikt, and Claude syndromes each arise from specific midbrain lesions affecting cranial nerve 3, the cerebral peduncle, and other structures, leading to distinct motor and sensory impairments. Similarly, spinal cord syndromes are characterized by the affected spinal tracts and the resulting clinical manifestations. From the hemisection of the spinal cord in Brown-Séquard syndrome to the anterior spinal cord compromise seen in anterior cord syndrome, each condition highlights the precise anatomical and functional organization of the spinal pathways. The importance of understanding these syndromes extends beyond diagnostic value. It is crucial for developing targeted management strategies which may involve medical, surgical, and rehabilitative interventions. This lecture aims to equip students, nurses, and residents with a foundational knowledge of these syndromes, guiding them through the key clinical and anatomical principles needed for accurate assessment and effective treatment. Topics. This slide introduces the primary topics we'll be covering in today's presentation on neurotrauma syndromes: anatomy, pathophysiology, and syndromes. Anatomy. We'll start by reviewing the relevant anatomical structures within the brainstem and spinal cord. Understanding the precise location of motor and sensory pathways, cranial nerve nuclei, and autonomic centers is crucial for recognizing the clinical manifestations of various syndromes. This foundational knowledge will set the stage for understanding how specific injuries or lesions in these areas lead to distinct patterns of neurological deficits. Pathophysiology. Next, we'll examine the underlying pathophysiological mechanisms. We'll discuss how infarctions, hemorrhages, traumatic injuries, and degenerative processes impact different structures within the brainstem and spinal cord. Knowing the pathophysiology helps in understanding why certain syndromes present with specific symptoms and how these conditions evolve over time. Syndromes. Finally, we'll explore various brainstem and spinal cord syndromes. Each syndrome will be characterized by its unique set of clinical features, anatomical location, and underlying cause. This section will cover both brainstem syndromes like Weber, Benedikt, and Wallenberg, and spinal cord syndromes including Brown-Séquard and central cord. Recognizing these syndromes and their presentations is key for timely and accurate diagnosis, which ultimately guides appropriate management and intervention strategies. Each of these sections will build on the previous one, helping us form a comprehensive understanding of neurotrauma syndromes and their impact on patient care. This framework will also provide valuable insight into the diagnostic approach and management considerations necessary for these complex conditions. Anatomy of the brainstem. The brainstem consists of three main sections: the midbrain, pons, and medulla oblongata. Each section contains important tracts and nuclei responsible for a variety of motor, sensory, and autonomic functions. Midbrain. Key structures. Cerebral peduncles contain the corticospinal and corticobulbar tracts, which carry motor information from the cortex to the spinal cord and cranial nerve nuclei, respectively. The red nucleus is involved in motor coordination, particularly in the rubrospinal tract, which controls limb flexor muscles. The periaqueductal gray matter, PAG, plays a role in pain modulation and defensive behaviors. Oculomotor cranial nerve 3 and trochlear cranial nerve 4 nuclei control eye movement. Blood supply to the midbrain is primarily supplied by the posterior cerebral artery and the basilar artery. Nearby tracts and nuclei include the corticospinal and corticobulbar tracts that run through the cerebral peduncles, the medial longitudinal fasciculus that coordinates eye movements, and the substantia nigra, which is involved in motor control and affected in Parkinson's disease. Vulnerabilities. Due to the small diameter of the vessel supplying the midbrain, it is vulnerable to microvascular infarcts, especially in hypertensive patients. Compression from nearby structures, such as a pineal tumor, can cause paranode syndrome, affecting vertical gaze. The pons. Key structures are the pontine nuclei that relay signals from the cortex to the cerebellum, involved in coordinating voluntary movements. The abducens cranial nerve 6 and facial cranial nerve 7 nuclei control lateral eye movement and facial expressions, respectively. The medial and lateral lemnisci relay sensory information to the thalamus. Blood supply to the pons is supplied by the basilar artery and its branches, including the paramedian, short circumferential, and long circumferential branches. Nearby tracts and nuclei. The corticospinal and corticobulbar tracts run through the ventral pons, carrying motor signals. The medial lemniscus relays proprioception and vibration sense. The spinothalamic tract, located laterally, carries pain and temperature sensation. Vulnerabilities. The paramedian branches of the basilar artery supply the ventral pons, making it susceptible to infarction from occlusion, leading to Millard-Gubler syndrome, also known as ventral pontine syndrome. A lesion affecting the ventral pons can lead to locked-in syndrome, where motor pathways are disrupted while consciousness is preserved. Medulla oblongata. Key structures include the pyramids, which contain corticospinal tracts that decussate, cross over, at the lower medulla. The inferior olive, involved in motor coordination, relays information to the cerebellum. The nucleus ambiguus controls muscles involved in swallowing and phonation speech. Hypoglossal cranial nerve 12 nucleus controls tongue movement. Vestibular nuclei involved in balance and spatial orientation. Blood supply to the medulla is from the vertebral arteries, anterior spinal artery, and posterior inferior cerebellar artery, also known as pica. Nearby tracts and nuclei. The medial lemniscus relays proprioceptive and vibration information from the opposite side of the body. The spinothalamic tract carries pain and temperature sensation from the opposite side. The hypoglossal nucleus controls tongue movement affected in medial medullary syndrome. Vulnerabilities. Occlusion of the anterior spinal artery can cause medial medullary syndrome, leading to contralateral motor and sensory deficits with ipsilateral tongue weakness. The posterior inferior cerebellar artery, pica, supplies the lateral medulla, and occlusion of this causes Wallenberg syndrome, also known as lateral medullary syndrome, with symptoms like loss of pain and temperature sensation on the contralateral body and ipsilateral face, ipsilateral ataxia, and Horner's syndrome. Anatomy of the spinal cord. The spinal cord is divided into four main regions: cervical, thoracic, lumbar, and sacral. It contains various tracts that carry sensation and motor information to and from the brain. Additionally, the spinal cord has a central gray matter core that contains neurons and glial cells. The dorsal columns, also known as posterior columns, carry proprioception, fine touch, and vibration sense to the brain. They are located in the posterior dorsal part of the spinal cord and receive their blood supply from the posterior spinal arteries. Nearby structures are the dorsal root entry zones, where sensory information enters the spinal cord. Vulnerabilities. This area is susceptible to damage in conditions like tabes dorsalis, associated with tertiary syphilis, and posterior cord syndrome caused by B12 deficiency or trauma. Lateral corticospinal tract carries voluntary motor signals from the motor cortex to the spinal cord, responsible for fine motor control. It is located in the lateral part of the spinal cord and receives blood supply from the anterior spinal artery. Nearby structures include the spinothalamic tract in the lateral spinal cord. Vulnerabilities result in motor weakness on the same side below the level of the lesion, as seen in Brown-Séquard syndrome from hemisection of the spinal cord. Spinothalamic tract transmits temperature and crude touch sensations from the body to the brain. It is located in the anterior lateral portion of the spinal cord and gets its blood supply mostly from the anterior spinal artery. Nearby structures include the corticospinal tract in the lateral spinal cord. Vulnerabilities in this tract result in contralateral loss of pain and temperature sensation below the lesion as seen in Brown-Séquard syndrome and anterior cord syndrome. Anterior horn cells, ventral horn, contain motor neurons that innervate skeletal muscles and are located in the anterior ventral part of the spinal gray matter. The blood supply is from the anterior spinal artery. Nearby structures are adjacent to anterior interneurons in the lateral corticospinal tract. The area is vulnerable to damage in anterior horn diseases like Pathophysiology. This slide introduces the key aspects of pathophysiology that are crucial to understanding neurotrauma syndromes, focusing on mechanisms of injury, the impact of trauma, oxygenation, natural history, and outcomes. Mechanisms. We begin by examining the primary mechanisms responsible for neurotrauma. This includes an understanding of how direct impact, acceleration-deceleration forces, and rotational injuries can cause damage to brain and spinal cord structure. Each mechanism has a distinct effect on the nervous tissue, resulting in varying clinical presentations. Trauma. Trauma is a major contributor to neurotrauma syndromes. Traumatic events can lead to both immediate and delayed effects such as contusions, hematomas, and secondary injury processes. We will discuss how trauma impacts neural tissue, blood flow, and the body's inflammatory response, all of which contribute to the progression of injury. Oxygen. Oxygenation plays a crucial role in the outcomes of neurotrauma patients. Hypoxia or impaired oxygen delivery to the brain or spinal cord can exacerbate injury by depriving cells of the essential energy needed for survival and repair. We'll cover how maintaining adequate oxygenation and blood flow is essential to mitigate secondary injury in neurotrauma. Natural history. Understanding the natural history of neurotrauma syndromes helps predict the progression of symptoms and potential complications over time. By studying how these syndromes typically evolve, we can better anticipate the needs of patients, recognize patterns of recovery or deterioration, and intervene more effectively. Outcome. Finally, we will discuss outcomes associated with neurotrauma syndromes. Outcomes can vary widely depending on the severity and location of the injury, as well as the timing and effectiveness of interventions. Recognizing factors that influence recovery is vital for patient prognosis and for guiding rehabilitation efforts. Each of these topics provides insight into the complex and multifaceted nature of neurotrauma pathophysiology, which is essential for accurate diagnosis, treatment, planning, and improving patient outcomes. This slide provides an overview of brainstem and spinal cord syndromes, highlighting the characteristic features and clinical presentations associated with each syndrome. We categorize these syndromes based on their anatomical locations, either within the brainstem or spinal cord. Brainstem syndromes. Brainstem syndromes are classified according to the structures affected within the midbrain, pons, and medulla. Each syndrome presents with unique patterns of neurological deficit due to the involvement of specific cranial nerves, motor pathways, or sensory tracts. Weber syndrome occurs in the midbrain, affecting the cerebral peduncle and cranial nerve 3, leading to ipsilateral oculomotor palsy and contralateral hemiparesis. Benedikt syndrome also arises in the midbrain and involves the red nucleus and cerebellothalamic tract, resulting in ipsilateral oculomotor palsy combined with contralateral ataxia or tremor. Paranoid syndrome is often related to a lesion in the dorsal midbrain, causes vertical gaze palsy and light near dissociation. In the pons, locked-in syndrome is a severe condition resulting from damage to the corticospinal and corticobulbar tracts, causing quadriplegia with preserved consciousness and vertical eye movement. Millard-Gubler syndrome and Foveal syndrome are pontine syndromes characterized by ipsilateral cranial nerve deficits and contralateral motor or sensory loss. Medullary syndromes include Wallenberg syndrome, lateral medullary, and medial medullary syndrome, both leading to distinct sensory and motor symptoms depending on the structures affected. Spinal cord syndromes. Spinal cord syndromes are defined by the level and region of spinal cord involvement, which affects motor and sensory function accordingly. Brown-Séquard syndrome results from a hemisection of the spinal cord causing ipsilateral loss of motor function and proprioception with contralateral loss of pain and temperature sensation. Anterior cord syndrome affects the anterior portion of the spinal cord, leading to loss of motor function and pain, temperature sensation, but sparing proprioception. Posterior cord syndrome is characterized by a loss of proprioception and vibration sense due to posterior column involvement, while motor and pain temperature functions are preserved. Central cord syndrome commonly affects the cervical spine, causing greater motor weakness in the upper limbs than the lower limbs. Cauda equina syndrome and conus medullaris syndrome involve the lower spinal or nerve roots, leading to bowel and bladder dysfunction, saddle anesthesia, and variable lower limb weakness. This summary table is a useful tool for comparing these syndromes, focusing on their anatomical location, structures involved, and main symptoms. Understanding these features is essential for accurately diagnosing neurotrauma-related syndromes and developing effective management strategies. The brainstem has a complex organization with motor and sensory pathways, cranial nerve nuclei, and autonomic centers. Brainstem syndromes are often classified based on the affected anatomical location, midbrain, pons, medulla, and associated structures. These syndromes are Weber, Benedikt, Claude, locked-in, Millard-Gubler, also known as ventral pontine, Foveal, Wallenberg, also known as lateral medullary, medial medullary, and paranodes. Weber syndrome is a neurologic condition caused by a lesion in the midbrain, specifically affecting the cerebral peduncle and the oculomotor nerve, cranial nerve 3. This syndrome is characterized by ipsilateral oculomotor nerve palsy and contralateral hemiparesis. Anatomy. The midbrain structures involved are the cerebral peduncle, the crus cerebri, which contains motor fibers from the cortex that descend through the midbrain, including the corticospinal and corticobulbar tracts. The oculomotor nerve, cranial nerve 3, nucleus, and fibers, which control eye movement, eyelid elevation, and pupillary constriction. Path of damage. The lesion affects the oculomotor nerve fibers, resulting in ipsilateral oculomotor nerve palsy. The corticospinal and corticobulbar tracts are disrupted, leading to contralateral hemiparesis or hemiplegia. Pathophysiology. Lesion location. The lesion typically occurs in the ventral median midbrain, affecting the cerebral peduncle and the exiting fibers of the oculomotor nerve. The causes of this syndrome include stroke. Uh, Locked-in syndrome is a rare neurological disorder resulting from damage to the ventral pons, the part of the pons in the brainstem. It is characterized by complete paralysis of nearly all voluntary muscles except for those controlling eye movements, leaving the individual fully conscious and aware, but unable to move or speak. Patients with LIS, locked-in syndrome, can usually communicate through eye movements or blinking. Anatomy. The primary site of damage in locked-in syndrome is the ventral pons. The pons is part of the brainstem and is involved in several critical functions, including motor control, sensory processing, and relaying information between the cerebrum and the cerebellum. Structures involved: corticospinal tract. Located in the ventral pons, this tract carries motor signals from the brain's cortex to the spinal cord. Damage here results in paralysis of voluntary muscles below the level of the face. Corticobulbar tract. This tract also runs through the ventral pons and controls facial and other cranial nerve-mediated movements. Lesions here lead to paralysis of the lower face, tongue, and throat, preventing speaking and swallowing. Preserved structures. The reticular formation, responsible for maintaining arousal and consciousness, remains intact, allowing full awareness. Eye movement pathways that control vertical eye movements and blinking are also often spared, allowing limited voluntary movement. Pathophysiology. Mechanisms of injury. The most common cause of locked-in syndrome is a stroke, typically due to an infarction in the basilar artery, which supplies blood to the pons. Ischemia in the ventral pons affects the corticospinal and corticobulbar tracts, leading to quadriplegia, paralysis of all four limbs, and loss of facial movement while sparing consciousness and vertical eye movements. Trauma. Traumatic brainstem injury can also cause locked-in syndrome by damaging the ventral pons. Demyelinating diseases, such as multiple sclerosis, can cause demyelination in the pons, leading to similar clinical features. Tumors. Brainstem tumors pressing on the ventral pons can mimic locked-in syndrome. Effects of lesions. Quadriplegia is complete paralysis of the arms and legs due to disruption of the corticospinal tract. Anarthria, loss of speech, results from damage to the corticobulbar tract, leading to paralysis of facial and pharyngeal muscles, preventing speaking and swallowing. Preserved consciousness and eye movements result from the dorsal pons, which houses structures related to arousal and eye movement and remains intact, allowing awareness, alertness, and some eye movement control, typically vertical movements and blinking. Clinical presentation. Locked-in syndrome presents with complete paralysis or quadriplegia, and patients are unable to move their arms, legs, or most of their facial muscles. Loss of speech and swallowing, anarthria, is due to facial and bulbar muscle paralysis. Patients cannot speak or swallow. Preserved consciousness. Unlike coma or vegetative states, patients are fully conscious, aware of their surroundings, and able to think, feel, and remember. Vertical eye movements and blinking. Most patients retain the ability to move their eyes vertically and blink, which is often their only means of communication. Intact sensation. Patients usually retain sensory perception, so they can feel pain, touch, and other sensations, but cannot respond physically. Workup of locked-in syndrome requires a thorough clinical evaluation and imaging studies. Clinical assessment begins with a neurological examination assessing eye movements, pupillary responses, and responsiveness to determine consciousness and motor limitations. Bedside communication tests assess the patient's ability to communicate through eye movements or blinking. Imaging studies for locked-in syndrome include a MRI of the brain, which is the preferred imaging modality to detect infarction, hemorrhage, or lesions in the ventral pons. Diffusion-weighted imaging is especially useful for identifying acute ischemic stroke. CT scan may reveal brainstem stroke, but is less sensitive than MRI, particularly in the early stages of ischemia. Additional tests. Magnetic resonance angiography or CT angiography are useful to identify occlusion or narrowing of the basilar artery, which is commonly involved in ischemic strokes that cause locked-in syndrome. Encephalography, EEG, confirms that the patient is awake and alert, particularly if the clinical assessment is unclear. Evoked potentials may help assess the functional integrity of sensory pathways. Management. Management of locked-in syndrome focuses on supportive care, secondary prevention of stroke, and enabling communication, as there is often limited potential for full recovery. Acute management for ischemic stroke. Thrombolysis can be done if the patient presents within the therapeutic window, typically 4.5 hours from onset, and meets criteria. Intravenous thrombolysis, TPA, may be administered. Thrombectomy. In cases of basilar artery occlusion, mechanical thrombectomy may be considered in the acute setting if anatomy and time constraints allow. Antiplatelet or anticoagulant therapy are useful depending on the cause of the stroke. Antiplatelet, aspirin, or anticoagulant therapy may be used to prevent further ischemic events. Supportive care includes respiratory support with mechanical ventilation, initially if respiratory muscles are affected. Patients for nutrition are often fed through a nasogastric or gastrostomy tube because of difficulty swallowing. Prevention of infections, bed sores, and muscle contractures with regular turning, skin care, and passive range of motion exercises are essential. Facilitating communication. Eye movement communication is important because it allows the patients to answer yes or no questions. Assistive communication devices with eye tracking technology can allow patients to select letters or words on a screen using eye movements, enabling more detailed communication. Physical therapy and rehabilitation. Physical and occupational therapy may help prevent muscle contractures and maintain joint flexibility. Some patients may achieve limited recovery with intense rehabilitation. Speech and language therapy. Therapists may work with patients to maximize their communication abilities, primarily through nonverbal means. Outcome. The prognosis for patients with locked-in syndrome is generally poor, but some patients can achieve limited recovery depending on the cause and extent of the brainstem damage. Recovery potential. Stroke patients due to ischemia may experience partial recovery over time, although full recovery is rare. Rehabilitation efforts can improve outcomes but are usually limited. Trauma and demyelinating disease as causes of locked-in syndrome may have a better prognosis if the lesions are not as extensive or if the condition can be managed medically. Long-term survival. Many patients survive long-term if given appropriate supportive care. However, the quality of life is often severely limited due to the profound motor impairment. Quality of life. While patients are cognitively intact, the inability to move, speak, or express themselves freely can be psychologically challenging. Assistive technologies for communication and the support of family and healthcare providers are crucial for improving the quality of life. In summary, locked-in syndrome is caused by damage to the ventral pons, leading to quadriplegia, anarthria, and loss of facial movement, while preserving consciousness and limited eye movement. Diagnosis involves imaging to identify the cause, often ischemic stroke, and management is centered on supportive care, communication facilitation, and secondary prevention of stroke. The prognosis is generally poor, with limited potential for functional recovery, although assistive technology can significantly improve the patient's ability to communicate and interact with their environment. Is most